Hello, my name is Marc Humbert. I'm a professor of respiratory medicine and the director of the National Pulmonary Hypertension Reference Center at University Paris-Saclay in France. As you know, the typical patients with pulmonary arterial hypertension used to be young females with no or few comorbidities. However, thanks to registries and better awareness of pulmonary arterial hypertension, we know that those patients may be more diverse. Indeed, this condition affects both genders, of all ages, and many patients present older with cardiovascular and pulmonary comorbidities. Therefore, it is important to recognize and to address the needs of these non-standard PH patients. It is not because you do not present with classical PH that you should be treated with less ambitious goals. We do set the bar high in order to improve quality of life, exercise capacity, and outcomes in all patients with PH, regardless of their comorbidities and risk factors. The most common non-standard PH patients are older than 65, with a higher proportion of males, and they often have several cardiovascular comorbidities, such as obesity, diabetes, systemic hypertension, coronary heart disease, or a lung phenotype with a smoking history and low DLCO, and they are more hypoxemic. The main challenge is to have sufficient awareness that pulmonary arterial hypertension may cause shortness of breath in patients with other more common reasons of dyspnea. Then the patient should undergo tests to measure the probability of pulmonary hypertension thanks to echocardiography, and then perform right heart catheterization if pulmonary hypertension is likely or possible. Then all the other tests should be performed to properly classify the disease. In clinical practice, these non-standard patients are getting more and more common thanks to better awareness in the community, guideline dissemination and implementation, and state-of-the-art evaluations. In many clinics, at least half of the patients with PAH are non-standard, especially because they present with cardiopulmonary comorbidities. Nevertheless, one should emphasize the need for personalized approaches in managing PH, especially in these non-standard cases. Several registry data and post-hoc analysis of randomized controlled trials underscore that such non-standard patients are not that rare, and that they should be diagnosed and treated meticulously according to guidelines. Personalized management should take into account all approved therapies, either as initial monotherapy followed by sequential combination therapy if treatment goals are not met, or careful initial combination therapy. We currently have 4 classes of drugs targeting the prostacyclin, the endothelin, the nitric oxide guanylate cyclase, and the activin pathways. All these medications can be considered in PAH, including patients with a cardiopulmonary phenotype, but not meeting the criteria of non-PAH associated with overt left heart disease or advanced lung disease. Our field is very active, and there are phase 2 and phase 3 randomized control studies analyzing novel therapies or new strategies for pulmonary arterial hypertension, including non-standard patients if they meet the PAH criteria. These studies often report sub-analysis of patients with cardiovascular comorbidity. It is clear that all patients with PAH should undergo all complementary analysis, including imaging by means of echocardiography or magnetic resonance imaging, lung function, including spirometry with gas transfer measure by DLCO, and blood gases, as well as invasive measures with precise estimates of pulmonary capillary wedge pressure and possible stress tests with exercise and free challenge if appropriate. Even patients with cardiopulmonary comorbidities can benefit from PAH medications. It is important that patients are managed in centers with multidisciplinary teams, with regular risk assessment, with guideline-supported diagnostic and therapeutic approaches. And these regular risk assessment should use validated tools. And most importantly, regular assessment and evaluation of treatment goals. Different specialists and healthcare professionals should be involved to address the complex needs of these non-standard patients and support them in a personalized way. The patient's voice is also very important in order to properly address key outcomes, including better quality of life, of course. Frequent assessments are important to track disease progression and adjust treatments as needed. A well-coordinated team with cardiologists, pulmonologists, rheumatologists, and healthcare professionals, including specialized nurses, will be able to provide a more accurate and timely understanding of patient status and adjust management as needed. In conclusion, it is important to reinforce the importance of ongoing research and emerging therapies in providing new hopes for all patients with pulmonary hypertension, including non-standard PAH patients. Our call to action is to encourage clinicians to remain informed about the latest developments and to consider a personalized approach in PAH management. Thank you very much for your attention, and please go to the PPCME website to return to the landing page to obtain credit and access other related topics. Thanks again.